good morning, good afternoon, and good evening to all the speakers, chairs, and the wonderful audiences in different parts of the world. Welcome to the ACNS webinar. The speaker for the first session today is our honorable guest from UAE, Professor Tomoso Tufo. Professor Tufo currently serves at the Dubai Oasis area as the head of surgical department and lead consultant neurosurgeon at Fakih University Hospital in Dubai, UAE. He works previously in the Centre Italian region and city of Rome as a senior consultant neurosurgeon at Policlinico Gemelli University Hospital IRCSS of Rome, Italy. He has managed over 3,500 complex neurosurgical brain and spine procedures for both adult and pediatric cases, including minimally invasive spine, complex trauma cases, neuro-oncology, and neuromodulation. He holds an academic position as adjunct professor of neurosurgery at the Catholic University of Rome and lead functional and epilepsy group, whereby Policlinico Gemelli University Hospital IRCSS is one of the largest neurosurgical units in Italy and Europe, which cover over 3,000 neurosurgical elective cases per year for both private and public, and more than 300 DBS cases for movement disorder. We are extremely honored to have him today at our webinar, and today he'll be talking about Frameless DBS for movement disorder technical aspect. The speaker for the second session of today is our honored guest from China, Professor Shi Hua Zhang. Professor Shi is the academic leader and director of the first affiliated hospital of Hebei University Hospital, China. He was a previous visiting scholar at the University of Iowa and Cleveland Clinic, United States of America. He reserved his expertise in management of cerebrovascular diseases and stroke. He's the chairman of the Neurointervention Committee of the Halo Young Stroke Association. He's also a noted author as well as editor of the Chinese Journal of Cerebrovascular Disease and Chinese Journal of Intervention Radiology. We are extremely honored to have him today at our webinar, and he'll be talking about the stage hybrid treatment for the management of complex AVMs. The chair for the first session of today is our distinguished faculty from Japan, Professor Shiro Horisawa. Professor Horisawa is a consultant neurosurgeon at the Department of Neurosurgery, Tokyo Women Medical University, Tokyo, Japan. His research interests are focused upon lesioning surgery like radiofrequency, gamma knife, and focused ultrasound. He's also specialized in deep brain stimulation, spinal cord stimulation, and interthecal backprophone therapy. He's an important member of the Japanese Neurosurgical Society and also a member of the Board of Directors, World Society for Stereotactic and Functional Neurosurgery. He's a noted author with several publications in various peer-reviewed journals. He's also received several awards and accolades for his outstanding contribution towards neurosurgery in his country. We are extremely thankful to him for accepting our invitation to chair the session of Professor Tomoso Tufo. The chair for the second session of today's webinar is our honored guest from the United States of America, Professor Sabaresh Natarajan. Professor Natarajan is currently Director, Brain, Tumor, Skull-Base, and Cranial Neurosurgery. He is also a consultant in the Cerebrovascular and Surgical Neuro-Oncology Institute at the St. Vincent Healthcare, Jacksonville, Florida. He's also a member of ACNS, CNS, as well as American Association for South Asia Neurosurgeon. He has been rewarded with several awards and honors for his outstanding contribution in neurosurgery. He's also a hybrid trained neurosurgeon and specializes in both clipping as well as coiling for aneurysm. He's a noted author with several publications in various peer-reviewed journals. We are extremely grateful to him for accepting our invitation to chair the session of Professor Shi Hua Zhang. On behalf of the Education Committee of the ACNS and the President, Professor Yukato, I would like to welcome both our speakers and chairs and the audiences to this online platform of ACNS webinar. A warm welcome to our colleague in China, and we are extremely thankful to Professor Zubin for broadcasting this webinar on WeChat channel. Dr. Ben from Hong Kong is my co-host for today, and with that introduction, I will hand over the online podium to our first chair, Professor Shiro Horisawa.
Okay. Thank you for your kind presentation, and welcome everyone to the ACNS webinar. So today, Professor Tufo will be presenting on the DBS with frameless surgery. And the frameless surgery has received a great attention with the advent of a robotic assisted surgical device such as the ROSA. So today we are very happy to hear the topic of frameless surgery for deep brain stimulation. So Professor Tufo, please start your lecture.
Good evening and hi to everyone. Thank you. There's really a nice opportunity to share my experience in this kind of field. Let's share I'm director of Surgical Institute here at Fakir University Hospital in Dubai. And I'm still holding my position as adjunct professor in Rome, where basically I started with the frameless surgical procedures in 2010, basically. So our hospital in Rome made a huge investment in movement disorder, and I started the practice there. I opened the unit, and then I had this opportunity to move to Dubai to start a new neurosurgical unit here, and I hope to go ahead with the movement disorder and the functional neurosurgery here too. I will show you some few slides, just because this our meeting they have a teaching purpose too, just to show how fast we moved. Basically, we have to consider that deep brain stimulation had always a great interest, from the beginning of our century. Of course, the first devices, they were built to achieve precise and small part of inside the head, basically, without any damage to important structure. And we can see here on the right side one of the first apparatus, basically based on the Cartesian three-coordinate system. And this was basically the same concept, and they helped us to go ahead with the deep brain stimulation implants and to start basically our practice, to move to something that is definitely new, like Professor Shiro just introduced in his presentation. Now here we can move to small progress in, I don't want to say small, but this progress during the few years, so basically in 20 years, in a really difficult period of our history, the interest in stereotaxy and deep brain stimulation, they grew a lot with the specific tools and the instruments designed to make this kind of procedures always more precise and accurate, with this kind of purpose to achieve really small area inside the brain without damage to important structure. And we can see that sometimes it was the real first stereotactic operation in the 1947. Is something well known by people that they do this kind of procedures. And this first operation was the coagulation of this dorsal medial nucleus of the thalamus in the patient with psychiatric disturbance. And it was a kind of start for functional neurosurgery and the DBS in that case. The surgery, we started to think about, do some interfere with some circuits, do some at that age, do some damage to some specific circuit to have some clinical result, therapeutic result. After that, I will go a little bit faster about the history, because during this kind of 50 years, we had a really quick development of new system and new devices. And this was the first DBS procedures in a Parkinson's disease patient in Rome. It was performed in my previous institute in the Gemelli University of Rome in the 1996. And we can see how the old, we can say old apparatus, so this kind of old frame was used in that case to achieve this kind of small nucleus and the subthalamus nucleus in that case in this patient. And it was something that now we can call old, but I can see that it was at that time really accurate and precise. And the result of the first procedures in our institute, I'm still following a patient with more than 30 years of follow-up with the deep brain stimulation. And this kind of devices, we can say, is still working after 30 years. And I can say, reviewing these images, that procedures done 30 years ago, I can still see that they are really accurate. So why deep brain stimulation and why this kind of interest in these techniques? We have to start from this because it's not just indication related to movement disorder. Like in that case, we will discuss more about Parkinson's disease, essential tremor, and dystonia. But is in the last 20 years, it's a kind of huge interest in different target inside our brain and the different target to treat different conditions that unfortunately they don't have other solution or they don't have other kind of effective treatments. Most of this study, there's a review of a couple of years ago. You can see there is still study in phase 2 or 3 that now in 2022 they just ended the phase 2 and phase 3, like in the Alzheimer's disease, in the Tourette syndromes, in the condition like OCD, and again some interesting field of research and of treatment like anorexia in that case, and this kind of disorders that they are quite diffuse in especially in the European population. And of course, some of the well-established treatment like DBS and in the epilepsy disorder that is becoming a kind of one of the options in case of the drug-resistant condition in that case. Just this line to show you what's really happened in the last 50 years. So the technological progress and the amazing work done on the devices really changed the story of DBS. It was the main progress that was done in the in research of new devices, new IPG, new battery with rechargeable option, new and that they can last till the latest one till 25 years. So and again with the design of a new electrode, new shape, directional lead, they made really the difference in this kind of treatment. But instead of this huge research in terms of new devices and new materials, in that case, not so much is really done about the tool that we are still using for this kind of technique. Because we have to, I want to show you this, what is really critical in deep brain stimulation procedures is this kind of point. So the imaging pre-op, intra-op, and post-op procedures is something really critical, and just in the last years we had the right attention to some specific protocol for imaging, not just for the planning as we will see, but for the localization of the electrode. Is really critical to understand where is our target, how we can reach the target, and where is our electrode after the procedures. Again, what is really crucial, the targeting, visualization, and the confirmation, because we were moved for a system guided by some coordinates. We are moving to a system that can allow us to reach the target without this kind of coordination system. And in this kind of system is really important to see our target clearly and the relationship with the surrounding structure. Of course, the different tools available for this kind of procedures that we can summarize in frame-based technique, frameless technique. We will put some focus on this frameless and the robotic assisted technique. We are now at the era, there is the era of the robotic assisted surgery still. Of course, there's the availability of a new brain atlas and the software for planning is kind of making a little bit easier our life in this kind of procedures, as well as the anesthesiologist technique and the intraoperative neurophysiology, that it was an important part on this kind of technique in the last 30 years, and we will see how is changing this kind of technique during the procedures. And of course, as we discussed, again, crucial roles in DBS is the new electrode design and the implantable pulse generators. This kind of point, they were nicely described in one of the recent review from this group that I just reported here. We can say I will put my focus specifically in my presentation will be about DBS Frameless and about the tools that we use for DBS Frameless. Why this? Because we are moving to a kind of technology and the tools that needs to be sustainable by the healthcare and by some hospital. And we know very well now when we propose a kind of a treatment, we propose some plan of a treatment for a condition, we have always consider what's the budget, what's the plan of the department, and if this kind of condition, of course, of option is cost effectiveness, and we will say this. I will put my attention in this kind of tools. Now we have the what we did. We did this kind of step. We moved from frame-based procedures, so it means use of the frame, and we have, I can say, beautiful frame and beautiful design to we can say, I remember the Maranello one that was a beautiful frame that the possibility to do bilateral implants at the same time to other more easier, but they need some investment at the beginning and they need to recheck and recalibration such after a certain number of procedures of a certain number of years, and is a kind of costly procedures, and this kind of frame they need a specific attention and training specifically to be used, and for lots of patients sometimes is still in our the feeling of the patient when you consider and you propose a procedures frame based is not always so well accepted. To consider to put a brain to put a sort of frame inside the head in now that is we are going through a less invasive, minimal invasive procedures, I can say is not well accepted from our patient at the moment. This kind of option, there are new tools. Not so new, I would say, because it's more than 20 years. Most of them, they are automatic. That allows us to perform the same procedures with good, the same accuracy and the precision, I can say, or similar to the frame based, so to achieve the same result and making our life and the procedures a little bit easier. In that case, I reported the StarFix apparatus. That is one. Is a system that we can basically print according to the plan of our surgery, is a kind of skull mounted system, as well as the next frame tower is another option, is a tool of a neuro navigation, because now we are moving from frame-based surgery to a navigation-based surgery, and we need some tool for navigation. And we will move to this kind of new apparatus, the smart frame, that is a kind of option that can allow you to visualize exactly where is your electrode during the procedures. And I think at the moment is the only one, because with the MRI scan, we can visualize the electrode without fusion of images, basically. The concept, of course, just to remember, this kind of easy concept, but is in this kind of a teaching presentation, is important to remark this. We have a sort of technology that allows us to reach a specific area, small nucleus, deep inside our head with respect of the surrounding structure. And this really we have to remember is like of the most advanced GPS system for our car, for our motorbike, and with the possibility to reconstruct in 3D our nucleus and our root. So that's how this system works. So this, and here in this kind of slide, we can see what's on the right side, what we need. So a planning software, an hardware, in that case, a neuro navigation, and a system, again, a software that can allow us to visualize the electrode and to merge, in that case, pre-op and post-op scan to confirm the position of the electrode. So I will show you some of the technical skills for using, in that case, one of the Frameless tool. In that case, this Frameless tool is nothing, absolutely nothing new. Is I think now is nearly 20 years that it is in the on the market, and there is nothing new in terms of the updated system for this. But we can see when they started to propose the Frameless system, why, you know, the attention and the we felt so strong enthusiasm in our surgeon, because moving from a frame-based procedures with the big frame, lots of steps to be, you know, respected and to be followed, to something that it was much more easier. So we accepted this with great enthusiasm. And why is it important to focus on new technique and new option in DBS? Because we are moving to a minimal invasive surgery. Minimal invasive surgery, I found this concept in the 2010 reported in this review that beautifully just did a sort of you know, summary of this idea, and it was nothing new. This is a review of 2010. There's the new frameless stereotactic delivery devices. There are novel ways, of course, to localize the brain target using the real-time imaging, and they are going to for a way to make shorter, safer, and less traumatic the procedures for movement disorder. That's the direction where we are going. So we need to consider this, because we have to consider minimal invasive procedures. So our patient, they want to discuss, they want to hear from us what is the minimal invasive procedures. Of course, there's something not new. The first one of the first reports of use of frameless stereotactic technique with the fiducial bone marker is from 2005. Is one of the first experience from the group of Philip Starr, and of course it was reported at that time accuracy, useful, and limits of the target. We decided in our institution to invest in frameless procedures in 2012, and we used this system in the last 10 years, and 168 patients underwent under DBS procedures, usually DBS technique, with the indication for the traditional and more standard indication for DBS like Parkinson's disease, dystonia, and essential tremor. And of course, our report just was in the literature from the 2010. The first studies, it was a big argue at the beginning, because some of the traditional centers, they preferred not to change their the way they performed the operation, and there was this discussion about accuracy and the precision of the system. Some small differences was found in some experience. Of course, we are just considering small cases in that case, but overall the accuracy and the precision, we can say, of the system is about the same. And here in this there's nothing new. There's some of the study with the comparison of the frame-based and the frameless system. You can see that the vector error was almost the same. And the most important thing that the result and the outcome, specifically in the two procedures with the two different technique, was not different. And we confirmed this with one of our last study last years. But I reported here just the most important study in literature. This one is nothing new, but again in the recent meta analysis from 2018 was confirmed that the accuracy of frame-based and frameless system for deep brain stimulation, we can consider that there is not so much differences in terms of effect of the procedure. So the effect was basically if the accuracy, we can consider sometimes a little bit more accurate the system, the frame-based system, but in terms of outcome of the patient, consider the different condition, there is not so much differences between the two techniques. Again, what we have to consider, there are still some steps that they didn't change during the last 20 years. So what we need still? We need still the fusion between one pre-op examination and the scanner that we need to use for our procedure. We still need fusion of this kind of to proceed to this technique, and this kind of option, of course, that's it means we still need software for fusion, and we still need work on this kind of software to improve the accuracy and the precision. Of course, lots is changing with the new 3 Tesla machine, and of course they are coming the 7 Tesla to improve visualization of our target. We can consider that direct targeting is kind of there's a standard of care in case of subthalamus nucleus or GPI. Is still not clear in case of VIM, and still the indirect targeting technique is still accurate in this kind of procedures, especially for essential tremor. I will just report basically step by step what's happening with the frameless procedures. In that case, in our experience, we are using as a tool of our navigation the one of the frameless tool, how it changes, of course, in terms of comfort of the patient. You can see you don't need to fix the head of the patient, and the different step is you can see there is not so much in terms of invasive. There's not an invasive technique. It is a kind of a standard fashion technique like the other procedures, incision, burr and positioning of the tool on the head of the patient. And again, what is the step one of the big, and I consider one of the big and the first source of error in this case is the procedures of manual alineation of the target. This kind of procedures in this kind of tool and frameless tool, I feel, needs to be improved, and is something that is improved by the robotic assistant tool. This kind of procedures to find, to try to find our target manually is still a source of error, and I think is one of the biggest source after the stability of the skull mounted system in this kind of tools. Of course, the procedures go ahead. That's how we perform the procedures with the microelectrode recording to confirm the registration of the nucleus, and we proceed with the stimulation and the assessment of the patient. In that case, is the awake procedures that is still valid, and in different university centers in Italy is still performed like this. Is involved a full team of neurologists and neuropsychologists in that case, not just to improve the precision and the accuracy of the technique, but as well as to work in terms of research field. So it's still approved. Again, in this kind of frameless procedures with this kind of tools, that's what I think another source of big error in that case. We have to set manually what's the length of the electrode. So we are performing a so precise and sub-millimetric procedures, but we have to set in different with this kind of tools. When you perform a surgery with these tools, manually the length of the electrode. This could be another source of error in this kind of procedures. And again, another font of error is the fixation of the electrode. When you use this tool, you have your surgical field is a kind of narrowed field, and when you do with the multiple tracking, in that case, when needed, you will find it not easy to block your electrode, and this could be a kind of source of displacement in that case. What we did in the last 5 years, we tried to make the procedures still easier, we tried, and we proceed with we add in our surgical room the intraoperative cone beam system. In that case, is the arm. We did this because we needed to check the position, and it was our main issue to check the position of the electrode in your operation room. And we follow it, and we started to proceed with the registration without the fiducials, and this kind of experience was reported in 11 cases by one group from Poland. Our results are ongoing on 50 patients, but we found that the registration without the bone fiducial was extremely accurate, and especially provided us with the diffusion of the intraoperative scan, provide us the position in real time of our electrode, and in some cases we can say we did some adjustment when we decided to reposition the electrode according to the real position of the system, according to the scan, the intraoperative scan. Of course, we are moving for something that needs to be less invasive, and it means more comfort, not just for the patient, but for the surgeon too, for the full equipe. The use of sedation, in that case with the dexmedetomidine, is helping in neurosurgery in kind of awake procedures and in our ICU unit, and is a kind of a standard during these procedures, these DBS procedures. And of course, the Pro DBS Frameless, of course, is we can see better patient comfort. You have an easier access to the patient in case of emergency, more easy management of the sterile field, and of course the support from the literature side that we have the same result and the comparable result and outcome of the procedures, frameless procedures compared to the frame-based, and of course the decreasing of the OT time, that is still important. The cons, that's really important, and that's specifically for this kind of frameless tool. We have to consider that the limited con of reachability is really crucial in some kind of a target, and is something that we can easily, in that case, using a robot assistant system, you can easily manage this kind of issue. If you have a specific target, not an easy target with a particular shape of the head of your patient, or the depth of the target is more than 100 millimeter, you have to consider other options. This kind of critical consideration, you have to consider this, because you cannot achieve your target if you are in this kind of condition. Of course, there's considering what is the cost of the system when you decide for such of treatment, and in that case, some specific limitation of this tool about the narrow surgical field. As we discussed, the source of error. Remember this, and it was clearly reported in this nice review of this year, from February of this year. Quality of imaging is crucial and is critical when you decide to move for this kind of procedure. Check what is the sequence decided with your radiology staff. Check your sequence, the quality of intraoperative scan. Of course, you have to control and check what's your frameless kit. Remember, you can have specifically for some, when you have some tool, you need to check if there is some damage to your tool. You can have some problems in that case, or when the consistency of the bone, specifically with the bone fixed tools, if it's not good, you can be in trouble. So you have to consider this kind of limitation. Consider again that we are working with the computer, software, and the registration problems. This could be a big issue. We are working all day with computers, and is just, remember, is a machine, and you can have issues with this. And be prepared sometimes if you don't feel comfortable with your registration or some issue with the software. Sometimes be ready to suspend the procedures. Don't take a risk if your software or your machine has some problems in that case. Of course, we discussed this, the manual trajectory alignment is so crucial in some of this frameless system. Consider that this could be source of error in your procedures. And of course, inaccurate electrode measurement and system with the fixing tools. Electrode traction, when you do the placement and you try to complete the implant with the device and the extension with the IPG. Consider when especially your resident is there, or to be present sometimes, specifically during the first surgery, be present, because some traction to the electrodes can lead to some damage on the same or displacement of this electrode. And again, poor team experience, that's something crucial. DBS and this kind of technique is not something that you can start from one day to the other. It's not something for a general neurosurgical team. You need multidisciplinary team, you need experienced team, because it could be an easy procedure without any issue, or could be one of the worst cases in your life if you don't have support and you don't have experience in such of cases. And then that's why we are moving, just because the solution and the technology advanced, they are leading to make a still more precise and more accurate this kind of surgery. The robotic arm is nothing new, because the robotic arm procedures is something started in the 80s, basically in biopsy surgery for brain by the Ben Abid team, and then moved. There's one of the robot available now with and we have a kind of long follow-up with the ROSA robot assisted surgery. And with the ROSA robot assisted technique, you can achieve a kind of accuracy that could be below the millimeter. So you can see that the accuracy certainly better compared with the other frameless or frame-based procedures. But remember, the system needs head fixation. Be sure to have the head fixation and check for the collision of your system inside your operation room. You have big tools, big machine in your operation room. You have to check that there is no collision between there, because this could be a big issue, and that could be a big problem for your procedures. But then from the ROSA one, there's a kind of another option, the procedures under intraoperative MRI scan guided. There's the only one system that provides the direct visualization in the real time of the electrode without, and you don't need the fusion in that case. You can imagine how the system that could be the spine demonstrated to be accurate, precise, and safe, but you can see how the comfort of the team is extremely reduced, and of course you need a high cost system. The intraoperative MRI scanning, we know that is one of the most costly technique that we have in neurosurgery. Again, what is extremely useful and now has an acceptable cost is we can consider with the help of the new software and the fusion and the segmentation software, we can have an idea in 3D of our target and the relationship with the surrounding structure, and we are moving from a local anesthesia procedures to a general anesthesia procedures. The experience of different groups, especially in Spain or US, to moving to procedures with the direct targeting and the general anesthesia has at the moment more than 10 years of follow-up, and we can see that we have comparable results, and lots of group they are moving in this kind of direction for performing more and more procedures under general anesthesia. The important thing we are considering is this an expensive treatment, expensive tools for selected cases, selected patients. Around the world now we have 200,000 patients. They were submitted to DBS and they have a DBS devices. And we can see more and more hospital and or management team and staff, they ask to us what is the cost effectiveness of our system. And lots of studies coming in this field to show that this kind of therapy, this kind of and the technique in that case is a costly treatment, specifically when you start and you implant the system, but during the year, the system is the patient under chronic, this kind of chronic condition. We can see that his cost is absolutely proved as a cost effective as option, and we are working in the country specifically with the reimbursement system on to achieve and to have better cost and better price from the company, and to have this kind of option for more people, and for have this kind of option covered from the insurance system also. Of course, we are moving again where we're moving to something that will be, of course, we will have a strong impact of the DBS with the artificial intelligence that is working in that case to achieve the better target, the better setting of the stimulation for our patient, and we moved to something that is real about the telemedicine, so that we can manage, we can check, we can provide a setting of this kind of cases and patient with a telemedicine system, and it is something really important. So what's in the future? where are you going? So there is interest in this kind of field. Someone did this kind of research and in literature, and we will find that there is really huge interest in DBS. So we can see from this review of literature from 2022, the number of publications about the DBS, the studies active still opened in terms of new indication, research project, and new target for this kind of therapy. And of course, consider again what's the DBS frameless in movement disorder. Why DBS frameless? We need to consider and we need to improve the patient control. We need to improve the time of our OT is really important. We don't need in that case calibration cost compared with the frame based. And of course, we have the support of the literature that is effective and accurate procedures. Again, the future we won't see, and we are talking about this, I think, in our meeting more than 10 years. We are waiting for a small implantable pulse generator without extension, without battery. We are looking for a closed-loop adaptive system, some of them available in the market now, but definitely we need something that needs to be smaller with less impact on the patient aesthetically. Also, we need to consider this in our patient. The system needs to be smaller and sometimes without need to multiple incision and or multiple cable in that case. And again, remember, when you start and you want to consider DBS as a part of your practice, consider this not just tool and technique are important. You need a multidisciplinary team, specific train, discuss the budget with your hospital, try to choose the technology that needs to be sustainable in your budget, in your hospital, and especially and most of the things, be enthusiastic for this technique and for the condition. Remember, movement disorder patient, they are not easy. Sometimes the patient, they are never happy about the result. They are really demanding patients. Sometimes you need to be enthusiastic, and this is sub-specialty. Remember, this is something really important to have. Again, a specific training for functional neurosurgery. So I want to say thanks. So I hope I just we will open a discussion after my presentation and just I'd like just to invite more and more young neurosurgeon to attend the meeting in functional neurosurgeon and to expand their skills in this kind of fields that sometimes is not easy. I know that not all this neurosurgical unit, they can have a functional neurosurgical unit, but it's something that's if you consider neurosurgery, functional neurosurgery is one of the branches that will have a great future, especially in this kind of field. And thank you very much for the attention, and you are welcome in Dubai or in Rome if you are interested in to discuss and with me about the option. You can write email, you can call. I'm always available. Thank you very much.
Okay, thank you, Professor Tufo. Great presentation covering from the history of functional neurosurgery to the recent advancement of the deep brain stimulation by citing the latest literatures. So we don't have any question on chats, but I have several questions to you. So actually, I have only performed the frame attachment surgeries, DBS surgeries. And but I think the frameless surgery is very favorable for patients in terms of the pain while the frame attachment. So I have so many problems with the loss of consciousness due to the vagus nerve reflex by the frame attachment pain. So I think the biggest advantage of a frameless surgery is reduction of patient pain. And so my question is, do you have any experience performing a radiofrequency ablation without frame? This kind of technique, is this possible?
So you mean that the focused ultrasound procedures or radio frequency technique? So as well, I don't have experience of radio frequency with frameless, but some group they tried this. Classically, you know, is a kind of now we are moving to you know, to neuromodulation instead lesion. So in Italy, and so they are not now. They try in that case to perform a focused ultrasound lesion instead of radio frequency. So we did this till 20 years ago, specifically for a monolateral tremor, basically, but with the frame based, but not with the frameless system. Is a kind of option that is coming again, you know, in certain countries, I think, and there we had lots of meetings, especially with some group from UK, that they are trying to propose again, once is that could be now the actual, you know, indication for radio frequency lesion. I think we can still consider in selected patient with the monolateral you know, symptoms, especially tremor, this kind of option. And but when it's possible, I prefer to give indication for focused ultrasound therapy in that case.
Okay, thank you. And the next, I think the advantage of a frame-based surgery is that it provides a stable surgical field by fixing the head on the operation table. So in case of a severe head tremor with essential tremor or dystonic head tremor, how can you manage such kind of patients with frameless surgery?
So there's you have to consider this. Our the pre-op assessment of the patient is really important. You can see that the frame based also a patient with a severe tremor. When you put the frame based and you put in the Mayfield, and the patient starting have a severe tremor condition, the frame based, you have this kind of you know, the feeling that is more stable. But believe me, you have you can have some issue in terms of positioning of the electrodes, because there is a sort of elasticity of the system. So that's not completely, you know, that's not so hard to tolerate this kind of severe movement. I think that a skull-based system sometimes could be considered more stable, because the patient you can see, and you know, this patient with the Parkinson's disease, if you try to stop the tremor, to try to fix, it will get worse. So the patient needs to be, because the tension, the fact that the patients feel this kind of tension, they feel blocked, sometimes makes it worse. So with I can say is we need nearly 200 procedures with the skull-based, skull fixed system frameless tool, and we had no issue with this. With the dystonic patient, we prefer to perform general anesthesia, of course, in some kind of case, or in case there is some severe tremor. In that case, I prefer to go for general anesthesia. I had the experience with the frame based, but this kind of the feeling that the surgeon has to have the head fixed, your method will still move. There is a sort of elasticity, you know, of your system.
Okay, thank you. And all of your patients required totally hair shaved due to the fixation of the fiduciary marker.
This I showed just a couple of cases where we did just to show the small fiducials, but usually in the last 5 years we never did this. We just do. I prefer don't make any shape. I know that sometimes for dressing could be not easy. You need to care a little bit more, you know. This, but there is that we know in neurosurgery there is no evidence that you need to shave the patient for have less, you know, infection rate. So in that case, I prefer not to have any shave, or just in case of a revision surgery or issues with the wound. In that case, I prefer to have the patient shaved. Yes.
And last question: how do you think about the future of a frameless surgery in DBS, and at this moment in the radiosurgery treatment, the gamma knife surgery, right? Gamma knife surgery, they do not use a frame attachment surgery. They use a mask fixation surgery. So how do you think about the DBS future direction in the frameless surgery?
You know that we have two completely different indication for. I believe in radiosurgery, in movement disorder. I discussed with some group from France that they are using this kind of option, and in selected patient, I can see that that radiosurgery, it works like the focused ultrasound technique. But in selected cases, what I think, what is the future from frameless in patient with the movement disorder? I think that we need, and the company, they have to invest a little bit on this kind of navigation tools, because these tools, they are really old at the moment. We are using tools from 20 years ago. I know that it's not easy sometimes one company to develop new tools or update some tools. But this, we have to consider, there's a part of neuro navigation. So it means neuro navigation needs to provide a new tool. Of course, this kind of, I believe in a sort of smallest robotic assisted surgery, because the robotic assisted surgery that we have now is still a big equipment in your room, and you need usually space for this. So what I believe is in a new tool, smallest tool, advanced tool for neuronavigation for the brain, and the smallest robotic assisted surgery in this. And of course, with the help of the artificial intelligence, we will have for each patient the best trajectory, not just the best target, but we have to consider when you implant an electrode. Some people, they always think about the target. That's not the target. That's the trajectory that because your stimulation is a big field. You have to consider different slides, a piece, a 3D space, not just a target in 2D space. So that's something, and I think that's one of the future. And you know, with the new technique for the local field potential and things, we will have. And with the help of the artificial intelligence, design the trajectory and design the target for each patient.
Okay, thank you. Anybody comments or questions? Dr. Ben?
Yes, hello. Yes, hello, Professor Tufu. And I'm Ben, one of the young neurosurgeon from Hong Kong. So thank you for your very detailed lecture on frameless DBS. My question is about what is your view towards the robotic system for the DBS? So will you consider, or what is the trend in the future that you think for the robotic system on DBS? My second question is about the intraoperative monitoring for the GA patient, general anesthesia patient with your frameless DBS. So what kind of intra-op monitoring you would consider in patient with GA DBS? Thank you so much.
Thank you for your question. So I think at the moment when we consider robotic surgery in DBS, we are talking about a robotic assisted surgery. So it means it's just an older. An older, it means that it can reduce some human error in terms of alignment, in terms of, checking the distance of some, but is not a proper robotic surgery. So it's just a robotic assistant. And I think my feeling at the moment, the different company, they have to work to make the system a little bit less expensive, because all these kind of devices, equipment, they are really, really expensive. And I think for a robotic assisted procedures is not justified to have a so expensive system. Of course, if you have a group with epilepsy surgery too, you do EEG, you have this kind of school, and you have multiple treatments in your, is something sustainable. But if you have to invest just for DBS in a robotic system surgery, I think is at this time is needs to be discussed, with the full team. In terms of general anesthesia, we have support of studies about local field potential and intraoperative recording. With the right anesthesia technique, there is no significant impact on the micro recording and on the local field potential. So you can perform this kind of recording during the general anesthesia. Also, of course, with the collaboration of your anesthesiology team, because they have to be there, they have to be present to the dosage of the different medication to be sure to have a good signal, basically.
And thank you, Professor. May I also ask, what is your view towards the directional leads for the DBS? So what kind of, may I ask, in your center, what kind of patients, what indicates, what are the disease pathology that you would prefer using a directional lead?
Consider this, that now directional lead will not save you if you put the electrode in a wrong position. So it means if you have a position of more than 2 millimeters, far away your target, the directional lead will not save you. So it means you need to reposition the electrode, because now the cost of the electrodes is quite similar, to the traditional one. All the company, they are proposing this new directional lead, and for us it's kind of easy. I prefer to implant in all patients. Of course, if in your center you have to decide in which kind of a patient you can have more benefit from a directional lead, I would suggest for the VIM, so for the tremor patient, you can sometimes you need to put in a directional lead, because still is not the target, the targeting is not so clear, and you need more help, I can say, for the programming of this patient. So just for the VIM sometimes. But now I will say, just because the direction of the research is going to the not motor symptoms in the movement disorder, directional lead, they are really helpful to sometimes modify your programming, because you have to consider not just the movement, the motor symptoms, but the non-motor symptoms. They are still important, and you have, if you have more option, for your programming, definitely you can do better, and you can offer to your patient more chance, of improving.
Thank you so much.
Okay, so thank you again, Professor Tufo. Okay, Professor Boone, do you have any comment?
May I ask some question, Professor? A very short question, Professor. First, I would like to know, without head fixation, how you determine the location of your burr hole. How you determine your location of burr hole? Because usually you use the frame to determine for our work. Secondly, Professor, do you think in the near future, awake DBS will be something in the past? And also, the use of micro-electrode recording are no more required with a good imaging. My last question, Professor, would you think that since DBS have been nearly 30 years, do you really think that neuromodulation does happen in DBS? Thank you, Professor.
Thank you very much. So about the position of a borehole, remember that this according your target. So it depends. That there are some, the subthalamus nucleus. You have to remember what's the shape. I prefer to have the borehole a maximum 2-3 centimeters from the midline end of on the coronal suture. You have to remember what's the 3D of your nucleus. Of course, it's completely different in case of the GPI, that you need to be more medial, and of course considering to try to reach as much as you can of the GPI. For the thalamus is again some other option. Again, you have to go sometimes consider an intraventricular route too. So the borehole is decided according to your target, but there is something quite standard, and the standard and the experience from the past to follow some few few rules is still valid. So that's not some. Of course, it is reported in literature in case of revision, in case of a patient with craniotomy in the same area. You can decide for a different access. There is some parietal access too that you can consider still in the STN, but it's really for selected patient. About the microelectrode recording, I think we are going through a new era where we need to provide a quick, minimal invasive procedures needs to be quick. Our management, our hospital needs to have our surgical room available. I think the era of microelectrode recording in this way is kind of will have an end, because our system now, they can record from the electrode. You can have a closed loop stimulation also. So I think this era that was more for research and will finish in few years. So that's my feeling.
And neuromodulation, Prof? Does neuromodulation works does really taken place in DBS? So based on the scientific evidence. So
do you mean what's the future of neuromodulation?
Yeah, what I mean is, does DBS really causing neuromodulation in the real sense, or does neuromodulation happen in those?
I don't understand. What do you mean the neuromodulation in this patient? I don't understand.
Yeah, because we used to do listening, and then we start have DBS in terms of we are thinking theoretically it causes neuromodulation effect. So over the past 30 years, do you see any evidence, clinical evidence to show that neuromodulation does happen to the targeted lesion, targeted area, Professor?
In terms of okay, no, I believe that we are going to more to a neuromodulation era. Of course, I don't think lesioning will be really for selected patient, and the fact that we will have more devices then can sometimes record, and we can say talk with our nervous system. I think definitely that would be the future, but consider again lesioning technique for selected patient, or in some places we know this, not all over the world we can propose a neuromodulation techniques for lots of reasons. In certain places where the patient they can't come back to you sometimes for follow-up, they have some severe issue and the symptoms. Consider in such of case lesioning, and you have to help your patient. Lots of patients they can't come back to you. They live in a rural area. There is really difficult to achieve cities and go back for the follow-up. So you need to be sure to propose the right treatment. And in such of case, I think neuromodulation could be not the right choice.
Thank you very much, Professor.
Thank you.
Professor Horisawa, your concluding remark.
Okay, that's all. Thank you again, Professor Tufo. That's a wonderful presentation. So we have to move to the next session. So please share the Professor Boone.
Yeah, okay, thank you very much. Now we move to Professor Natarajan to introduce our second speaker, Professor.
Thank you, ACNS, for inviting me to chair this session. AVMs have been a topic which have been very close to my heart for a long time because they're very formidable lesions. First thing is, when do we treat them? Understanding hemodynamics and imaging of AVM. And then the modalities. I do surgery, endovascular embolization. I also do radiosurgery. When to choose what, when not to treat, when to stop, and what combinations. And then ruptured versus unruptured AVMs. How do you handle them? What is the timeline in ruptured AVMs? So there's a lot of nuances and decision making. And then there is a lot of, I think, clinical intuition in treating these patients, and experience plays a big role. I am excited to invite Dr. Shi Huizhang, who has been practicing neurosurgery with a special interest in vascular and endovascular neurosurgery for 26 years, from what I understand, at the First Hospital of Harvard Medical Center in China. He is an editor of multiple journals in China and has been as well written and well known in the field. I am curious to see what his take is on how to mix these treatment modalities for AVM and how we can achieve the best outcome of our patients.
Okay, thank you, Professor Natarajan, and I'm very glad to share my experience about the staged hybrid operation in the complex intracranial AVM. AVM is still a very challenging disease for each neurosurgeon, and the cerebral hemorrhage and seizure are the most common presentation. The annual risk of hemorrhage from cerebral arteriovenous malformation is approximately 3%. And for the predictors of the AVM rupture, a study from World Neurosurgeon reported that the deep and infratemporal location and single arterial feeders and single drainage vein and the presence of presence of varices in the venous drainage and co-exciting aneurysm. All of this is associated with the hemorrhage occurrence. A meta-analysis from the neurology shows that the hemorrhagic presentation and the increasing age are predictors of hemorrhage during the follow-up. Now, the most common grade system is Baszler-Martin grade. In addition, Lawton grade provide a supplement of the Baszler-Martin grade in age and ruptured precision and diffused with a maximum score of 10. These two grading systems help us to evaluate the risk of the operation. Notice there are several treatments of the AVM. If the patient is asymptomatic and there's a low risk of hemorrhage or incurable, I think the conservative observation maybe is an ideal choice. But most cases we should treat it using the microsurgery, because the microsurgery choice is the mainstream, I think. But notice if we choose the microsurgical surgical resection, we should using some new instrument or some new techniques, including the DTI, the neural navigation, and the intraoperative ultrasound or neurophysiology monitoring or hybrid operation. The third one is the endovascular embolization, because there's a lot of new materials like onyx and gluburon and some new techniques like the pressure cooker and the transvenous approach. All of this make the endovascular embolization the curate. The rate is more higher than several years. The fourth one is radiotherapy. But it's useful for the deeper and the small AVM. But we think the different combination may be applied to treat the high-grade AVM. The treatment of AVM, I think, still is very challenging because the objective of the treatment should be completely laryngectomy. And at the same time, we should minimize the focal neurological deficit. The two aims, I think, is controversial. For example, for the microsurgical resection, it can achieve the complete obliteration rate about 96%, but could lead to a higher mobility in high-grade AVM, especially for those involving deep adequate areas. Embolization may be more safer, but they always fail to completely remove the lesion. This can maybe lead to a higher risk of the hemorrhage after the partial obliteration of the AVM. And the radiotherapy maybe it's good for the small one, for the deeper one, but for the high-grade AVM, the result is poor. So for the dilemma of treating the high-grade AVM, the several studies have showed unsatisfied result. This study is from the Tiantan Hospital, showed the overall clinical outcomes for microsurgery of high-grade AVM were poor. About 1/3 patient got MRS score more than 2 when discharged. It's not a very good result. So they showed that diffuse naders and the purpurator feeders and the cortical spinal tract involved and the post-operative cerebral hemorrhage were risk factors of poor clinical outcome. And so what about the palliative treatment? If we obliterate the part of the lesion, embolize the patient, a part of the lesion, can we achieve the good clinical outcome compared with just the observation? From this study, they showed the partial treatment forced to prevent the hemorrhage, rather increasing the risk of rehemorrhage. So it's, I'm sorry. So this they tell us so we should choose either we leave the AVM, the lesion alone, either we completely remove all the AVM. So to get this aim, we should using the multimodal combinatory treatment. Now, looking at the history of using the stage treatment of the AVM, the first paper we researched is in 1987 from the UCSF. There's about 28 complex AVMs. They underwent the multiple surgical procedures, all endovascular embolization, and then followed by the surgical treatment, and they get a good result. Another study of combined treatment from the working neurosurgeon was performed among 114 AVM of Spicer grade 3 AVM. Non-ruptured AVM, they treated with the radiosurgery is 47.8%, and the others was ruptured. They treated with embolization, and after that they treated the neurosurgeon. All the AVM of the Specialist grade 3 they can be treated safely and effectively with surgery combined with the either radiotherapy or embolization. And the small size and the deep location and the deep venous drainage and the focal neurology deficit predicate a worse prognosis. What about there's a different kind of the combined ways. So what about which one is better? So the first one we see the embolization plus the radiotherapy. The evidence from the JNS showed that the AVM treated with the embolization plus the radiotherapy is associated with the lower obligation rate than those with the radiotherapy alone. So it's interesting. So the reason this might be because the embolic the materials can shield the needles from the ignoring the radiations and may obscure the outlines of the AVM, making the targeting with the radiotherapy difficult. And the next one, we let's see what about the radiotherapy plus the microsurgery. Also, this study showed that the inadequate the radiotherapy might cause the new nourishing vessels or narrowing of the drainage of the veins of the AVM. All of this can increase the risk of the later removal of the AVM in the open neurosurgery. So it's not very good, I think. At last, let's see the embolization plus the microsurgery. A study from the neurosurgery illustrates that the patient in non-embolization group had a worse MRS score than embolization group. It's only 38%, and the only embolization group is only 7%. So it's a very good result for the staged group. So resections of the M without embolization was independent risk factors for poor MRS score. So this is very important. Another evidence proves that pre-surgical embolization significantly reduced the lesion volume. This also is a good thing. This can contribute to a safe and effective resections. So let's summarize the advantage of the pre-surgical embolization. So the first one, it provides the better control of the feeding arteries, reducing the flow of the AVM and consequently minimize the blood loss. And the second one is some high risk factors can be treated during the embolization. For example, the deep feeders and the high flow fistula and the feeding aneurysm and the feeders from the duro. All of this can be treated during the embolization. All of this is really hard to treat it during the open neurosurgery. And the third one is the embolization provide a bloodless surgical plan. It's between the brain and the AVM, the interference, and the glue. Onyx glue can mark the brain AVM, the interface. So the interface is very important because from this plan, we can more easier to dissection. We can make the operation more easier and less neurological deficit and reduce the operation duration and so. The fourth one is the degradation of the lesions was realized by decreasing the size and eliminating the part of the adequate area. I think is also very important. And the last one is the intraoperative DSA can show the residual lesion during the operation. so we can avoid a second cranial ectomy. Since pre-surgical embolization shows a good result, shows a favorable effect, so many centers perform the one-stage hybrid operation. Now, all these procedures have been increasingly used for AVM in recent years, but there's still some limitation for one-stage embolization, one-stage hybrid. The first is it's a long operation and anesthesia duration, because we know it's not easy to embolization for the AVM, and it's also not easy to resect the AVM using the microsurgical operation. So if we do both the operation in the same time, in the same operation, it's really need a long time to finish it. At least, I think at least 5 hours or 6 hours and longer. So it's really not good. And the second one is the second one it's a dramatic hemodynamic change in one-stage embolization. So it will lead to the normal perfusion pressure breakthrough. Is maybe after the operation, it may be blood. So the third one, it may need the complex equipment because it need a hybrid operation room. Yeah. So we think a concept maybe is more better is a staged hybrid operation. So we propose the concept of the time interval. It means that after the embolization operation, we should wait for a few days, and after that we do the open surgery to resect the whole lesion. Yeah. The advantage of the staged hybrid operation, I think the first one is allows the gradual normalization of the parallel lesions, the hemodynamic and the vascular inflammatory reactivity, especially for the AVM with a large size and high flow fistula, to mitigate the risk of the MPPB caused by excessive reperfusion injury. And the second, it improved the tolerance of the neurons. The still phenomenon results in chronic hypoperfusion in the perileginal areas. Thus, the ischemic penumbra underwent reperfusion injury when the AVM is occluded. Our buffer period allows the better readjustment of the neurons in the penumbra. I think it's better than the one-stage hybrid operation because it can minimize the second injury during the immediately craniotomy after reperfusion in the penumbra. The third one, I think a staged procedure might effectively avoid surgical and anesthesia complication. Because many studies showed the prolonged operation duration and anesthesia duration and blood loss are significantly associated with the increased risk of overall post-operative complication rate. Yeah. But what is the best time interval? I think it remained undefined. If it's too long, I don't think it's good because some studies showed the palliative embolization AVM may tend to recruit new feeders and released a new deep venous drainage over a few months. This can negate the advantage of the pre-surgery embolization. So but if it's too short, I think it's insufficient adaptation. So we think maybe 2 to 7 days is a good period. Let's looking at the state treatment related study. This study showed from the Stanford, and they treated the 20 patients using the staged resection. All the patient was the Spezler-Martin's grade 4. Median grade is a grade 4. Mean AVM, the diameter is 5 centimeter, and 7 patients were ruptured. Embolization were confirmed in the 17 cases. The median interval between the embolization and the resection was 28 days. The outcome was achieved in the good result in 14 cases. Embolization in another this another study, 27 patients with the AVM underwent the staged embolization and the microsurgery with the average embolization sessions was 1.6. The mean embolization related morbidity was 3.7%. The staging interval were usually between 2 and 7 days, is similar than my centers. The Onyx made either dissection and better hemostasia. The surgical obligation was very high, it's 92.6%, and about 70% of patients achieved a good result. MS score is less than 2. Now turn to the data of our center from Harvard Medical University. We treated the AVM using the staged hybrid operation from 2015. From 2015 to last year, we treated 25 cases. 24 cases was the supra-temporal, and 1 is infra-temporal, and half patient is ruptured and half is unruptured, and about 22% the patient is adequate, and 28% cases is non-adequate. Spezler-Martin's grade 2 is 11 cases. Grade 3 is 9 cases. The complication rate, disability complication rate is 12%. The average session embolization is 1.08. The median staged interval is 5 days. The curative rate is 100%, and mortality rate is 0, and the APPB rate is 0. Regarding the long-term follow-up, all patients underwent a long-term follow-up in our study. The average time was the 38.41 months. As shown in the table, the MRS at the last available follow-up was overall significantly improved from the baseline. This score improved significantly in all cohorts, regardless of whether the AVM was ruptured or of low grade. The good neurological outcomes were observed in 22 patients, including all the unruptured annular AVM and 75% ruptured AVM. So taken together, our data preliminary showed a safe and effective outcome in treating AVM. I will show 3 cases in my centers. The first case is it's a right territorial AVM. This MRI T1 and T2. And from the DSA, the right MCA is a feeding arterial, and this right ICA angle we can see the feeding arterial from the right MCA, and from the left ICA angle we can see the feeders from the right ACA. And from the left vertebral arterial angle, we found the feeders from the right PCA. So the feeders is from the PCA, MCA, and ACA. The first stage, we treated the patient using the embolization. And the first one, we embolization the patient from the MCA, a small branch of the MCA. This is the angle after the operation. The others from the MCA, I think, is very superficial and is easier to control during the open surgery. So we don't treat it. We don't embolize the embolization this part of the AVM. And after that, we treated the patient from the ACA. This is before the operation. And we treated the ACA embolization from the ACA. This is the cast after post the operation. And this is the angle post operation. Because ACA, the feeder is more deeper than the MCA, so we should embolize more and more. It can make the open surgery more easier. So for this case, this is the AP view after the post we embolization the ACA. We embolize the ACA totally. But I think the most embolization should we should focus on the PCA, the feeders, because it's the deepest feeding. So this before the operation. And we embolization from the PCA, and this is the post-operation. We showed most AVM from the PCA was embolized. Only a small, a tiny feeders. It's really hard to navigate advanced microcatheter to this one. So I think it's not very difficult to control during the operation. So we finished the first stage, the embolization. This is the CT scan post embolization. And 1 week later, we take the second microsurgery operation, and this is the midline. And it's easy to tell which part is the lesion, and we dissect, and we dissection, and we are easy to find the large and the large vessel, the large feeders arterial, but the arterioles was filled with the onyx. There's no blood in the arterial. And another large vessel, and we just cut the vessels and see what is in it. The black one is the onyx glue, and it's another. It's from the PCA, so it's a very large one. If we don't embolization this arterial, because it's very deeper. So if it's a bleeding during the operation, so it's really hard to control it. So it's the last one. This one is the drainage vein. It's the last thing we should treat it. Before the operation, the vein is the red one, and now it's the blue one. So we can treat it. We can coagulate. We coagulate and cut it and the final. So this is a CT scan post operation, the patient have a good result. So this case is the first case that we treat the patient using the staged hybrid operation. So the good result give us a very confidence to treat even such the case using the staged hybrid operation. We take the DSA follow-up. The left one is the pre-operation, the right one is the post-operation. It's from the right axis, the angio showed the good results. This MC is the feeding, and this AP view. And this from the left axis view is showed the ACA feeding, is AP view. And the last one is the left vertebral arterials angio is pre-operation, is post-operation. The PCA feeding is good result. So the second case is from CT. We can the right temporal lesion here, and this is MRI show the AVM as the right temporal lobe. And from the DSA, we can show the right ECA is a feeder. It's a dural feeding. And from the right ICA, we found the MCA is also the feeder. And there are also a feeder aneurysm here. And from the vertebral arterial, from PCA is also the feeder. So for this case, we should embolization three the vessel. The first one is the feeding aneurysm, MCA. The second one is the PCA because it's a deeper, it's a deep feeder. And the third one is from the ECA is a dural feeder. So the first stage I treated the MCA, the feeder aneurysm, and we treated using the onyx glue. This is the during operation, and this after operation the aneurysm disappeared. And this is a 3D scan. We can find the glue. And after that, we treated the PCA because it's a deeper feeder during the operation. Open operation is really hard to control. This is the post-operation. So the CT scan, not a CT scan, it's 3D scan. For the ECA, we don't treat it because maybe I think it's superficial. Maybe we treat it. It's not very hard. This is the CT scan after the embolization. The patient shows no asymptomatic, and after that we take a DTI. We want to know the important area and the AVM, the relationship. The DTI, I think, is very important before the operation, and this during the operation, this monitoring, we using the video. This one is the dural supply. It's really hard to control. I think next time I will treat it embolization, the ECA at first. Because when we want to calculate, it's not easy to control. This is the final. After that, everything is easy because there's no more blood supply, so it's more easier. Just like resect miniature. And after we resect the whole lesion, we take the angio And from the angio, we saw a residual AVM. So we try to looking for the residual AVM, and we found it, and we evaluated it. And after that, we take the angio again. From this DSA, they showed there's no AVM, so it's a good result. It's a CT scan 1 day post-operation and 4 days post-operation, and MRI post-operation. The patient a good result. The last one is ruptured AVM, and there's a cerebellar hemorrhage and hydrocephalus. We take the CVD at first. And we'll take a DSA examination, show the AVM at the right cerebellar, and the feeding arterial is from the SJ, from the PECA, from the ECA, and we embolization after the first embolization, we saw the glue. And we take the angio, show the AVM small than the first, and 1 week, 5 days later, we take the second embolization. This CT scan after the second embolization, and the angio, AP view and the lateral view. From the lateral view, we found the AVM also from the PECA, from the SCA and the ECA. This part, all of this part, we embolization. From this one, I think it's superficial. It's easy to control during the open operation, so we don't treat it using the embolization. This is the final result after we resect the whole AVM. This from the left vertebral arterial, and this from the right vertebral arterial. It's performed as the hybrid operation room. So this is the final result. The CT scan. We found the onyx, the glue, the cluster. All the cluster is in the near the midline, so it's very deep. So conclusion, we think the appearance of my center. I think the first one for the first stage, the endovascular embolization, we should focus on the feeding arteries. It's not nethers, just the feeding arteries, because the first reason is it's more easier to navigate to advance the microcatheter to the feeding arteries. It's more than to the nethers. It's more easier. The second one, from the arteries, feeding arteries, the embolization, the glue is not easy to influence the venous. It's very important. The third one is we don't want to the glue into the nethers, because if we a lot of glue into the nethers when we treat it using the microsurgery operation, it's hard to resect it. It's very hard. It's very hard. So we just navigate the microcatheter just into the arteries. It's better than in the nethers. And the second one, we should treat some high risk factors. For example, the high flow feeders, the aneurysm, the dural feeders, and the deep feeders. So all of this we should treat it during the embolization treatment. And the second stage is the microsurgical resection. So the first one, we should protect the drainage vein. It is very important. The second one is we should remove as completely as the all the lesion is very important. So the third one is we should using the DTI neural navigation and all of these things to make the operation more safer. And if we have the hybrid operation, we should take a DSA examination during the operation. If there is a still residual, we should treat it. So let's summarize the advantage of the stage hybrid procedure. So the first one is can reduce the intraoperative the blood loss, and it can reduce the difficulty of the procedure. It means both the embolization and the microsurgical resection, and can reduce the risk of the complication. The second one is can decrease the flow of needles, increase the adaptability of the perilescent vessels bed. This is very important because this gradual normalization of hemodynamic reduce the risk of the overperfusion after a sudden obliteration. So the third one, if a patient with AVM located in adequate areas shows a post-embolization system, the subsequent microsurgery should be performed after the nerve function is recovered. It means we should wait more days to let the patient recover. It's just, I think it's just like the boxing game. If we beat the patient with a hook, the patient fall down and stand up again, and we beat it a straight punch. The patient maybe fall down again and stand up again. But if we beat the patient with the combination, maybe the patient will never stand up again. I think the embolization just like a hook, and the microsurgery resection just like a straight punch. So because if one stage the hybrid operation, because it's the patient should at the general anesthesia, we have no chance to tell if the patient have some function deficit after the embolization. So I think it's very good. It's a very important advantage of the staged hybrid operation. So the fourth one is it can reduce the operation and anesthesia duration. Because in my center, all the both the embolization and the microsurgical resection was done by myself. So I don't want to treat it at the same time. It can save the power and energy of doctors, I think, and greatly reduce the requirement of the equipment for the hybrid operation room. At the 2015 years, the first we finished the first cases. At that time, we have no hybrid operation room. We just embolization the patient in the interventional operation room, and after that, we tend to the 1 week later we treated the patient in the operation room in the microsurgical resection. So thank you.
Excellent talk, Professor Husang, and a great illustration of experience and expertise, and understanding what you should do and should not do with an AVM. I really want to re-emphasize some of the important things that you mentioned in this, which is first, curing an AVM is very, very important. Partial treatment is not an option because that's actually more dangerous. Microsurgery still is kind of the best way to cure an AVM, unless you understand how to cure an AVM endovascularly, which I have done in some cases, but it's still a minority rather than the majority. Basically, it is just thinking about an AVM like we do in microsurgery, where you have to take the venous outflow to cure an AVM. So if you can do that safely with an endovascular technique, and the anatomy and the angio-architecture of the AVM is feasible to doing that, then you can attempt that. The thing you emphasized about minimal embolization and not filling the nidus, which makes surgery difficult, and understanding the AVM difficult, is a very important nuances. The last thing is, I think, performing a directed embolization, which is helpful for the surgeon rather than just embolizing the nidus as a whole, is a very important nuance in hybrid neurosurgery. The questions I had for you is, I commonly choose starting from high risk features embolization is the first priority. The second is actually the small feeders and deep feeders. And the last will be the major feeder if needed, if it is deep. I normally like to leave the major feeder for the surgical exploration rather than for endovascular treatment. Unless I'm going to attempt a cure with that, then I take that with a pressure cooker technique. Sometimes I do both arterial and venous, and I take the entire AVM endovascularly. So is that your philosophy, or how would you choose your feeders during the embolization?
So it's a good question. So if the feeder is a very, very large feeder, it's very high flow feeders. If we treated embolization from this high flow feeders, I think it's dangerous because the glue may be into the venous. If into venous, I think it's maybe we should treat it immediately, open the surgery. So I prefer to for most cases, I think the deep feeder is not very high flow. It's a small one. From the PCA, from the ACA, it's a small one. Usually from the MCA, the feeders is very high flow. But MCA is most of the MCA's feeders is superficial. So I will keep it when we treat it using the open surgery. It's not very hard to control. So I prefer to focus on the deeper feeders, small feeders. Yeah.
When do you choose radiosurgery in your armamentarium for treatment of AVMs?
Yes, in some cases, I'm not sure today. If I designed to stage the hybrid to treat the AVM. The first one, embolization, and after that, I will to resect using the open surgery. But if the glue can spread very good, the nidus, most part of the nidus is full. It's filled with the glue. So in those cases, I don't want to. After the embolization, I will send him to the gum knife. The doctors. I don't want to open surgery to treat it because there's small part of the AM residual. So for those cases, I will send to the gum knife. Yeah.
So, I have done the same too, but I always debate on that decision because we know an incompletely treated AVM is not a safe AVM, right? So if we treat an AVM and let's say we get 90% obliteration, there's still a little bit of venous filler. Is that a safe situation to do gamma knife? or should we resect this? Are we in a more dangerous situation than where we stored it, right? And I think the jury on that question is still out there, and I don't think there is a right answer. I've gotten away in some cases. I've had cases where I sent the patient for a Gamma knife and the patient came back with a rupture after that. So I think we need to be very careful in those cases. We need to talk to the families and patients and make them understand that this is a gray zone. We don't really know or understand this at that point. The question is if it's safe for resection, even though it looks very well treated or 90-95% obliterated, do we still need to take it out? Or do we need to treat it with a Gamma knife? So that is, what do you think about that?
Yes, I think the more important is not the volume of the residual AVM. It's I think the drainage of the vein. If the drainage vein is good, I think the hemorrhage the risk is not very high. I can send to the Gamma knife. If the drainage the vein is not very good, it's very tiny. Maybe I think maybe it will hemorrhage. So I can open surgery to treat it.
That makes sense. So your treatment for Gamma knife followed by embolization is really an afterthought. You don't plan that in the first place. You plan to embolize.
Not the first choice. Not the first choice. Yeah.
Got it. Do you ever just treat AVMs with Gamma knife without embolization or surgery?
Maybe very small one. I will send to the Gamma knife. And the deep one, small one. There's the tiny feeder and the tiny the drainage vein. Because if the for some cases, from deeper cases, if the drainage vein is very good, we can treat it from the embolization from the vein approach. Yeah.
Thank you. Open the podium for any other questions. Boone, you have any questions? Ben?
I have one question, Professor. Regarding those asymptomatic patients and also a very high-grade AVM that you prefer not to treat. So what other modality or medication that you can give at least to make the patient not so suffering from knowing that they're having such disease? And how do you actually follow up and to say that what are the changes that you take into the consideration when you want to offer some intervention, Professor?
You mean the grade 4 or grade 5?
There can be a high grade that you don't treat from beginning, or there can be also a low grade that asymptomatic that you also don't treat. So how do you, what are the changes that you look for and how often that you look for to decide when you want to start intervention?
Yes. If the patient is asymptomatic, it's a very huge AVM, and I think it's really hard to cure it. I don't want to treat it. So I think if I have the confidence to cure it, I will treat it. So for the grade 4 or grade 5, maybe I don't want to treat it. If the patient is not hemorrhage, I don't treat it.
Would giving antihypertensive or beta blocker is a way to make the patient slightly feeling better, or is just useless, Professor? If giving a medication like a beta blocker, would that help, or just no? Is actually no point, Professor.
No, I think the medication is useless for the AVM. I think maybe Sarah maybe I give some medication. So if the patient has no symptom. Symptomatic, I don't using the medication. I think, yeah.
Thank you, Professor. Dr. Sam, there's a question from Dr. Sam.
Hi, good evening, Prof. Shi. Sam from Malaysia. Similar question to what Dr. Liu has asked. I have a few grade 4 and grade 5 patients whose main complaint is just headache, would you suggest even partial embolization as a palliative treatment for them?
Oh, it's a good question. Yeah. Maybe a few years ago, I don't want to treat it. I don't want to touch them. Yeah. But in recent years, because the embolizations, the new materials and the new techniques should be used in the embolization rate. So I will treat it. But first choice is embolization. It's embolization. So because I have seen some complicated cases, some doctors cure it using the embolization the waste. So I want to try nowadays. Yes.
Yeah, but there's a risk of increased hemorrhage and all that. But I guess we just have to explain to them that risk.
I think as a lot of the doctors said, if you want to treat the AVM cases, you should know the anatomy. You should know the imaging. So when I want to treat it, before we treat it, we should know which part, because if there is some aneurysm here, I will treat it the aneurysm at first. If so, we will treat it the high risk the factors in the AVM in the lesion. Yes.
Okay. Thank you.
So I would like to add to that question. I think, in a grade 4 or grade 5 AVM, which is severely symptomatic, there is no medical therapy at this point, and surgery is very high risk, right? So I think commonly these patients present with headache is their main complaint. And, the biggest reason I think is for the headache is the high flow through the AVM. So if you can reduce the flow through the AVM without compromising the major venous outflow, or for that, it's very important to understand the angio-architecture of the AVM. In my opinion, the compartmentalization of AVM is actually from the venous side and not from the arterial side. Previously, we thought, we have an MCA compartment, we have a PCA compartment, we have an ACA compartment. No, that's not the case. It is a compartment for each draining vein. And it's important to understand that concept, that it's a venous is the origin of the disease and not an arterial origin of the disease. And if you're treating a multi-compartmental AVM, which is commonly the case in stage 4 and stage 5 AVMs, it's very important not to take any compartmental vein. Okay, if you decrease the venous outflow of even the smallest compartment out, then you're going to be in a rupture situation. If you can reduce the flow of the AVM without compromising the venous outflow of any compartment, then you may achieve some symptomatic reduction.
Mm-hmm. Yes.
All right. Okay, great. Thank you.
Professor, thank you for your lecture. So from your lecture, you mentioned about the stage procedure might decrease the risk of the normal pressure perfusion breakthrough. So my just out of curiosity, says how do you study the normal pressure perfusion breakthrough during your postoperative period? So is there clinical studies or any hemodynamic studies from at your unit? So, and I also want to ask for those patients that you deliberately choose to manage by stage procedure, either, for example, embolization flow with radial surgery or embolization flow with microsurgery. So how would you manage the blood pressure during your operative or interventional period?
Okay, so I haven't the clinical study for what you said. I want to do so. I want to do such a clinical study. maybe I want to know if it's just it's a concept. I think after the embolization, maybe the small vessels between the AVM and the normal arteries maybe is can turn back to the normal. I think because we reduce the blood flow, reduce blood flow. So I think after that, when we do the open surgery, we resect the AVM. Maybe it could be reduced the hemorrhage rate post the operation. This is just a theory, but I have any evidence to prove it. Maybe next time I will do some clinical research to prove it. Yeah, and during the after the embolization, after of the embolization operation and before the surgical operation, we should control the patient's blood pressure to avoid the hemorrhage. Yeah.
So how would you manage the blood pressure during or after your intervention or surgery?
Just control the blood pressure. I think it's enough. Yeah. If the after the embolization, if from the DSA, you can the drainage vein is good. I think the hemorrhage rate risk is not very high. Yeah.
I see. Thank you so much. Just because I think, as mentioned by the panelists, that partial embolization might have a risk to change the architecture and maybe diverting the flow into another compartment of the AVM. So I think the blood pressure management would be quite crucial in those with partial or staged embolization.
So Ben, I think Professor Huizhang mentioned this in his lecture that, as long as you do not reduce the outflow of an AVM, partial embolization can be done safely. Right. I think the mistake is that people do not understand the angio architecture well. And when you if you accidentally embolize an outflow of an AVM, it's going to be risky. So you can do a partial embolization as long as the outflow is preserved and you're still fine, right? If you understand the pathophysiology of normal pressure perfusion breakthrough, it is because the hemorrhage actually happens in the normal brain, not in the AVM tissue, right? Mm-hmm. So when the AVM is alive, and even you have a rupture after an embolization, it is not due to normal pressure perfusion breakthrough. It is because of rupture of the AVM itself. Right? The normal pressure perfusion breakthrough happens after the AVM is cured or taken out. So we are talking about two different things. You're asking him if you do a partial embolization, we are not in a situation of normal perfusion breakthrough because normal pressure perfusion breakthrough happens only after you're taken the AVM out, right? So when you're taken, for that, you do a different thing. You put in perioperative beta blockers. You keep the patient's systolic blood pressure after resection for 48 to 72 hours at a very low rate so that the patient's hemodynamic reserve and ability to compensate for pressure changes comes back in the normal brain. So that's a very different situation than a partial embolization situation.
Thank you so much, Professor.
Thank you, Ben. I think we're reaching our end of our session today. We have a very long session, but a very fruitful session. So I would like to request a concluding remark from Professor Natarajan. Professor.
Professor Zhang, that was an amazing talk and great insight and experience were shown in the way the talk was designed and the cases were managed. I appreciate all the panelists in asking amazing questions so that this was a worthwhile discussion of our time. Thank you, ACNS, Raja, Boone, for inviting me to chair the session. Thank you.
Thank you very much. And our first chair is still here. So we would like to conclude our session today. On behalf of the Education Committee of the ACNS and the President, Professor Yukato, I would like to thank both speakers of today, Professor Tommaso Tufo and Professor Shi Huai Zhang, and as well as the chairs, Professor Shiro Horisawa and Professor Savaresh Natarajan, for the time and support for the ACNS webinar. I would like also to express my sincere gratitude to Professor Zubin for broadcasting this webinar on WeChat channel. And special thanks to my co-host, Dr. Ben, for joining us today. And until we meet again on 22nd of April, next Saturday, it's bye-bye from all of us. Thank you very much, Professor.